Thank you very much. My name is Edward Boyer. I want to thank you for the opportunity to speak. A couple of things to get out of the way. I'm an emergency physician. I'm a medical toxicologist. I don't have any conflict of interest other than giving expert witness testimony in Kratom-related matters, even to the point that I haven't accepted compensation from the American Kratom Association or any other trade organization. And that kind of makes sense if you think about it, because Chris has talked about the basic science of why these molecules work the way they do, and Kirsten has talked about why people use them in the way they do and the effects that they have. But I'm a medical toxicologist. I deal with poisonings, overdoses, adverse drug events, and drug interactions, and no pharmaceutical company in the world, no dietary supplement manufacturer, no food manufacturer ever wants to test their substances for poisoning. So, whereas they have the great advantage of being a scientist, I'm more like I'm slightly different, because they can recruit people and do controlled trials. The people who come to me have to have an event, and then somebody has to recognize that the event has occurred and then make a connection with the substance, and then they'll perhaps call me. So a lot of the toxicity that's reported related to Kratom is just purely by happenstance. And whenever you see happenstance, you have to think in terms of biases that occur. So I'm going to focus, we've talked about like the science, we've talked about the benefits, and I'm going to talk about the risks at this point. So when I think about the risks associated with Kratom use, it falls down for me in two primary areas. The first is going to be seizures, and the second is going to be respiratory depression. So for seizures, to give you a little bit of context, this was many years ago, and Chris was involved in this case too. It was somebody who was injecting an awful lot of Dilaudid. His wife told him to stop using drugs. He said, give me a couple of days. He learned about Kratom. This was back in 2004 or so many years ago at this point. He began using Kratom 3 to 4 times a day. He did this for 3 years, and he noticed that he's more alert. He's paying more attention to his wife. He's getting work done. Now, you could say it's because he's not injecting full-bore opioids several times a day, or you could say it's related to the Kratom. We can't say that one way or the other, but regardless, he notices that he's now paying attention to his wife, and he decides to see if he can boost his level of alertness a little bit more. So being a junior pharmacologist, he takes a modafinil tablet because that's something you use to increase your alertness. Didn't want to overdo it. He cut it in 2. He took half the tablet and drank a cup of Kratom tea the way he normally makes it in the dose that he normally used, and suffered a generalized tonic-clonic seizure, which brought him to care at Massachusetts General Hospital, where they had never heard of Kratom before. So we got called as toxicologists. We went over, and after the evaluation, we found that literally all he had taken was modafinil. We were able to prove that what he'd taken was Kratom. We wrote this up as a case report as a potential adverse event related to Kratom, but you have to classify it in that exact vein. It's a potential adverse event associated with Kratom use. It doesn't prove causation. It doesn't prove that Kratom caused the seizure. But a couple of things pop out that are really useful to keep in mind about the seizure and Kratom world. The first thing is that, do people suffer seizures after using Kratom? Yeah, they do. On the other hand, do people suffer seizures after doing literally almost anything? Yeah, they do. So we don't know how strong the evidence is just based on that. So we have seizures associated with Kratom. But now you have to look a little bit deeper at whether or not they've had a seizure disorder. A lot of individuals who use Kratom who've had seizures have a known seizure disorder. So it's not entirely surprising that they're going to seize again. You want to look at the medications or other substances that people have used, and the majority, I'm not going to get into numbers about the proportion that will have done this, but the majority seem to have used multiple substances. How those drugs interact is an area that must be investigated if we had enough patients that we could actually look and figure out if there's a pharmacodynamic interaction between those two substances in that individual. So if you look at the substances, you need to look at whether or not they are pro-convulsant substances. Do the other things that they've taken with kratom actually cause seizures themselves? And in a decent proportion of individuals, certainly in Malaysia, yes, they do cause seizures. So is it correct to say that kratom caused seizures in somebody who has a seizure disorder or used another substance known to cause seizures with kratom? It's probably not correct from a scientific perspective. But what about those individuals who don't use another substance, who have no risk factors for seizures, who have no other substances that they've used? What about those folks? Well, if you take those individuals, and this is a research study that has been performed with a small number of individuals. Take those individuals with no risk factors, no history of seizures, no concomitant drug use, and do an EEG. That's where you put a whole bunch of leads on their head to determine if they have abnormal electrical activity in their brain that can predispose them to seizures. The answer is yes, they do. So they did not seize up to that point, even though they're at increased risk of doing so because their brain has that electrical activity at baseline. So can we say that kratom causes seizures? I think the answer is clearly no. You can't say that there's causation there, although there is an association. Does somebody who have seizures following kratom use need an additional workup? And I think the answer there is yes. I mean, we know from the cocaine experience, there were an awful lot of people out there in the 1980s, 1990s using cocaine. There were some that would seize from time to time, but the number of people who used cocaine was vastly larger than the number of people who developed a seizure. So a lot of toxicologists say that if you use cocaine and you had a seizure, you need to work up for a primary seizure disorder. And I think it's probably a rational recommendation for kratom as well. If you seize without any risk factors, without any concomitant drug use, without a proconvulsant medication, you need to work up for primary seizure disorder. I'm going to pivot a little bit now and talk a bit about respiratory depression. And what Chris didn't tell you, and what I don't think anybody's told you yet, is I'm actually a chemist. I'm a synthetic organic chemist, and then I went off and did other things following. And a lot of my work was in the shape of molecules. If I make a model of a classic opioid, like I take morphine or heroin or hydromorphone or codeine and make a molecule of it, it's kind of a T-shaped molecule. And that binds into the mu-opioid receptor, MOR. Those molecules produce a lot of biological effects. They produce euphoria, they produce analgesia, they produce pupillary constriction. They have effect on mood related to euphoria. They alter gastrointestinal transit time. So there's a lot of biological effects that they mediate. So it's a T-shaped molecule that goes into a receptor that causes a lot of outcomes. Mitragynine different. Mitragynine is flat. It cannot fold into a T-shaped conformation. So it binds into the mu-opioid receptor or interacts with the mu-opioid receptor in a fundamentally different way. Now, how can you take a T-shaped molecule and have all these effects? Well, they're massive molecules, they transmit across, but because they're massive molecules, they're always changing shape. And if you bind in a particular way, then you stabilize the shape of the molecule that produces pupillary constriction and respiratory depression and analgesia and GI gastrointestinal transit time. So you stabilize the receptors that produce all of those things. You take a flat molecule and put it in there, and it doesn't do it. It doesn't do all of them. It only does some of them. And even the ones that it doesn't do perfectly, not nearly as well as the native molecule. So the classic mu-opioid receptor ligands, the morphines, the heroines, the dilaudid, the oxycodones, the oxycontins, the hydrocodones, they have that T-shaped structure. They produce the universe of adverse events that we expect from opioids. They're called unbiased ligands. They have no bias towards one particular biological activity or another. Mitragynine, being a flat molecule, stabilizes only a couple, and then not very well. It's considered, and it's actually called in the literature, a biased mu-opioid receptor ligand, because it doesn't cause some of the things that the classical ones do. It does not seem to produce respiratory depression to the same degree. Now, can I knock that out? Yeah, perhaps I can. Perhaps if I give enough, I can stabilize all the universe of conformations to produce the universe of biological activity, but I don't know the dose at which I can do that. I don't know the other drugs that I can take that will do that. So to say that Kratom and mitragynine induce respiratory depression, I don't know that there's a whole lot of strong evidence for that. In fact, there's actually kind of some evidence the opposite direction. You know, like we know, back from the 1960s, that if you took a rat and drew up a whole bunch of mitragynine in a solution and injected 600 milligrams of mitragynine per kilogram of rat, they would have no respiratory depression whatsoever. So there's testing, there's animal testing that suggests strongly that there's no respiratory depression. And what's more, there are also pharmaceutical products that are not in common use, but nonetheless have been patented, they have IP protection, and they are FDA approved, which are biased ligands. So the big pharma recognizes that biased ligands are a potential way to go too, in terms of creating new molecules. So that's really what I wanted to talk about. That's where, for me, the rubber hits the road with Kratom use, and I would look forward, when all were done, to take any questions related to it. So thank you very much for your time, and again, for the opportunity to address you.